Yeah, yeah, we can see.
You can see it?
Yeah.
Sorry, could you see the video?
Yeah.
Okay.
We're able to see.
It hopefully go well.
Multiple क्या है? I think you have to click on slideshow because there are multiple screen. Yeah.
I have multiple monitors here on my side. I'm now on slide view now at this moment. And I'm sharing my screen. What do you see now? Do you see the presentation mode or what do you see?
You have to click on display setting.
Okay.
Duplicate slideshow. Yeah. It's fine now.
Okay, perfect.
Yeah.
Let me just see here.
So welcome back, and we are really honored to have Professor Steen with us here today. He's a reputed immunologist and microbiologist whose research on tuberculosis has been widely established. Professor Steen and his group work on host gasotransmitters, MTB redox homeostasis, and bioenergetics, the role it plays in latency and persistence of mycobacterium inside the human host. Professor Steen is professor at AHRI, Africa Health Research Institute. Previously it was known as KERIT, KwaZulu-Natal Research Institute for Tuberculosis and HIV. It's a HHMI institute. It's a privilege for all of us to listen to him. So, Professor Steen, all yours.
Sorry, you broke up there. Can I start?
Yes.
Okay, well, thank you very much, everybody, for the introduction. I'm going to talk about a slightly different topic, which was just mentioned. I'm going to focus on the human TB granuloma or lesions using high-resolution X-ray imaging technologies. And I have to say it's a privilege to present this seminar. I only have fond memories of all my visits to India, Delhi, Chandigarh, in Calcutta, and as many of you may know, I have a significant number of Indian postdoctoral fellows in my lab here at RE as well as at UAB. Anyway, so let's just jump straight into the seminar. I'm going to give you, let me just see here. Oh, there it is. Just to give you an idea on the content, I'm going to give you a little bit of background on tuberculosis. I'm going to talk a little bit about the spectrum of TB lesions using imaging tools. And then I will present a couple of new findings, and then I'll talk a little bit about COVID-19, how COVID-19 can help us understand TB lesions that characterize the human tuberculous lung. Firstly, I have to say this is an institute in Durban, South Africa on the east coast, northeast coast, close to Madagascar, the Madagascar side of South Africa. We have a very nice laboratory there, funded by the Immuno Medical Institute and the Wellcome Trust. And then, as you may know, I have a lab at the University of Alabama at Birmingham also. I'm responsible for the RE Human TB Lung program in South Africa. What we focus on, what we study is the human TB lung. A lot of attention is focused on studying how does TB cause disease. Very simple, but also a complex question. To do that, we we receive resected lung tissue from two local hospitals, Albert Tutuli Central Hospital, as well as the King Dinizulu Hospital. We receive 3 to 4, sometimes 6 freshly resected lung tissue samples per week. Most of them are elective surgery and emergency cases. The emergency cases are slightly less. We get a few of them a month. And within about an hour, my postdocs would go with the surgeons into theater, and tissues would be removed. Within an hour, we would receive this fresh tissue and take it to our institute, which is about 50 minutes away, and we do flow cytometry and whatever we want to do with it. Collaboration with our cardiothoracic surgeons, as well as pathologists are extremely important. We have a very productive collaboration going on. More recently, we've also developed a very aggressive post-mortem program where we are studying latent TB. These are my collaborators. Many of you may know Robert Hunter, which is one of the few remaining TB pathologists worldwide at the University of Texas in Houston. And then I have a number of cardiothoracic surgeons and a lot of pathologists, forensic pathologists, anatomical pathologists, etc., etc., and then postdoctoral fellows. So these are the people that sort of directly involved with the science that I'm going to tell you today about. Most of the work has been done on by Gordon Wells here on the bottom left, research associate, Kavesh Narka, and also Kupongo. Just to give everybody an idea, this is an open book cut of a 400-fixed human TB lung. You can see the two sides of the open book cut. You have a cavity on the top, left and right. You can see multiple nodules or tubercles, evidence of massive necrosis. You can see these big lesions here, and then you get smaller lesions, evidence of fibrosis. Oxidized blood is more sort of the darker areas. This is on the left-hand side, in A, you see the right lung, severely diseased, being removed, and this is post-surgery. In C, you can see the patient standing up, you see the air there, and this is fluid-filled lungs. So we received these lungs. Like I said, some of them are formed and fixed, and some of them are fresh, which is a useful reagent for the study of human pulmonary TB. This is just to illustrate a miliary TB case. On the left-hand side, and on the right-hand side, it's slightly cut open. You can see the white tubercles. If you rub your fingers over the pleural surface, you can feel these nodules. So this whole lung is completely destroyed. It has a separate independent cavity, but it's just filled with TB granulomas. And this is a zoomed-in image. So this is the focus of a lot of attention in the TB field, understanding what really is going on in a human granuloma. We know so much about granulomas and model systems, but ultimately we know very little about the human granuloma. This is a video that I will show you. This is a 400-fixed lung in the Department of Anatomical Pathology. This is very typical. They're going to cut it open and you can see for yourself. So you can see the white areas there. This is cases necrotic. Lesions, the whole lung is basically necrotic, is completely destroyed, and no surprise, this lobe had to be removed. A necrotic lesion like that has a profound impact in terms of pulmonary hypertension on the patient. It's very systemic. So when you remove the lung or the lobe, so severely diseased, within a few days, the patient typically feels perfectly fine. Their lives have completely changed. 4 or 5 days later, post-surgery, they're active, it's just completely different. So that's just to give you an indication of what the disease that TB triggers. So the question is, why is studying the human TB lung important? And I can say with certainty I had interest in TB decline with the introduction of antibiotics way back in the 50s. And decades later, today, we've realized that the disease had not been eradicated. As a matter of fact, several decades ago, it was publicly declared that we will rid the world of TB, and we obviously know today that's not the case. More importantly, no single animal model accurately reflects the full spectrum of human pulmonary TB. There's great value in animal models, but they represent the different stages of disease throughout the course of infection. There's no single animal model that reflects the full spectrum. I emphasize that, put it in red here, because I do believe it's important. If we have difficulty in describing human pulmonary TB, how can we productively study or cure it? With today's tools, we have spatial transcriptomics, we have single cell sequencing, we have all these fancy technologies. However, it's useless to apply these technologies if we can't describe disease progression. how does TB cause disease? We have to understand, we should be able to describe it in order for us to actually productively study it. And that is lacking, I believe, in the TB field. Whoops, let me just, yeah, okay. So in terms of the clinical spectrum of disease, more a clinical overview, broadly speaking, I'm not going to go into detail. We have latent TB somehow evolved into subclinical TB, and subclinical TB evolved into active TB. So both in the case of latent TB and subclinical TB, they're typically asymptomatic. In other words, they might have evidence, for example, in the case of subclinical TB, you would have an abnormal chest X-ray, and the patient will feel fine, despite the fact that the individual has an abnormal chest X-ray. And in some cases, the patient actually might be sputum positive, right? So that is a predicament. How do you study disease? When the patient says he or she feels fine, it has abnormal chest X-ray, and they could be a sputum positive. So subclinical TB is more or less in the middle between latent and active TB. Latent TB is more a clinical observation. It's very difficult to pinpoint it, but I might give reasons why I believe so. In the case of latent TB, you have a positive skin test, but no clinical symptoms of disease. Active TB is perhaps the most easiest to diagnose. You would almost certainly have an abnormal chest X-ray. You may or may not be sputum positive also, and you will feel really sick. You'll feel bad. Now, why is it important to determine the spectrum of human TB lesions? Number one, the spectrum of human TB lesions is uncharacterized. We know what a caseous necrotic lesion is, we know what a cavity is, and that's about where things stopped. So many decades ago, this was an area of very active research, and my view is that we need to decode the spectrum of TB lesions from a modern day point of view to understand how disease progresses. So we need to decode what we see, and for that we need a set of rules. So the necrotic granuloma, many diseases, foreign particles can actually cause this trigger granuloma formation, but the necrotic granuloma is highly characteristic of TB. But it's not necessarily the most important. It's perhaps the easiest to draw and the most popular depiction in textbooks and in articles, these round little circle, with all the cell types. But in my view, it might even be the least important, because it represents the end stage of the disease, when the host immune system kicks in an attempt to control the disease. What I personally find the most interesting would be all those stages prior to development of this necrotic granuloma. What lesions are generated before the necrotic granuloma? That's the attention of our focus, because that's mostly undescribed, and it would be of importance to understand the cellular and genetic features of the different stages, the features of the spectrum of different lesions, because that will allow us to predict where are these lesions going. Are they progressing? Are they regressing? Are they healed? And that's very important. I have to emphasize that all these lesions likely present environments that facilitate long-term persistence in the disease. That's the usual, what we see, many people have written about. There's a lot of speculation, very little evidence for this. And then also, understanding the lesions would help us explain why maybe some drugs do penetrate better than others. So there's a lot of advantages in terms of studying the spectrum of the human TB lesions. The evidence on the granuloma structure, a lot of papers have been published for decades now, more than 100 years on granuloma structure, and our focus obviously is on the 3D lesion structure. And here is just a number of papers where they refer to this actual 3D shape of the structure. Mostly it's been referred to as spherical. And it's not necessarily wrong. But let's look at what the definition of a granuloma, what exactly is the granuloma. This is from a paper published by Neil Reddy a couple of years ago. We see this very characteristic necrotic, caseous necrotic lesion. But the typical phonological definition of granuloma is an arrangement of 4 to 6 epithelial histiocytes that may or may not be accompanied by Langer's giant cells, and they may or may not be associated with necrosis, and lymphocytes, with the latter may organize randomly amongst histiocytes, or may form a cuff. So there's a formal pathological definition for a granuloma. In this particular case, you can see a cavity on the left-hand side. You can see the necrotic regions, as is evident by the yellow lines. So one could argue, well, maybe the disease, the case is the lesions coalesced, they merged, integrated, and the disease eventually erupted into an airway and ultimately generated a cavity on the left-hand side. So there's numerous questions that one would like to ask. What is the oxygen concentration, the degree of vascularization, what's the pH inside the necrotic lesion, inside the cavity, what's the drug concentration in the different areas, what's the metabolic state, cellular composition, etc., etc., etc. How do we determine the age of the granulomas? Are also very important but an outstanding question. And again, why is there the massive pathology but the few bacilli? And there is just two examples of, a neutrophils infected, one histiocyte, another one a neutrophil infected with TB. It's a dual stain, and that can range from 1 bacilli to 20, 30, 40 bacilli. So there's a lot of questions that one can ask from the study of human TB lung tissue. Naturally, access to the tissue is also important. Let me go on and make the point that the spectrum of lesions in terms of its growth pathology is reflected within an active lung. Again, this is an open book cut on the left and the right hand side of a lung. You see multiple evidence of necrotic tubercles. You can observe this grossly. You see evidence of irreversibly dilated airways, which is this yellow circles here. You see evidence of fibrosis there. You see the smaller type lesions, and this is all macroscopic. You can see this by eye, right? So microscopically, you can see much more, and you can see the full spectrum of lesions in virtually every TB diseased lung, ranging from what we would view as latent lesions to active, progressive, regressive, and healed lesions. So this is an enormous resource for the study of the mechanism of TB disease. Let me give you an example of the pathological spectrum of pulmonary lesions that we are in the process of studying. This is an apparently healthy, there is a healthy airways of alveoli in a healthy region of a TB-infected lung. From the same lung, moving forward. Okay, there it is. From the same lung, you can see evidence of granuloma formation. You see mild inflammation and plugging basically of the alveoli. That increase, you get a more structured, non-necrotic granuloma filling in the alveoli. That increases in size. You start to see the formation of giant cells. You see a further increase, multiple giant cells. Ultimately, you get massively alveolar consolidation again with giant cells, and you will get necrotic lesions, and you would see evidence of a healed scar if the lesion is contained. And then you can also see evidence of calcified lesions, so the calcium crystals sort of got pulled out by the microfilm blade, but you have this round ball of calcium in its lesions. Then obviously you have the tubercle formation, and you have cavity formation. So the idea is to characterize the full spectrum of lesions, and there's multiple levels of these lesions. If you talk about a cavity, it could be a thick-walled cavity, it could be a thin-walled cavity. So there's sort of minor deviations from what I've just shown you, which we're trying to study on the genetic and on the cellular level. A question that we frequently get is why the massive pathology of the few, if any, bacilli. I mentioned that before. In many of these cases, you see very little bacilli, if any bacilli, but you see massive disease. But perhaps it's just they might be there, we just can't see them. Okay, so the key points, take-home message is, the question is, how do we identify those lesions that progress, regress, contain, and heal infection? What are the cellular features of those lesions? What are the genetic features of those lesions? If you look at the latent lung, you might see, and that has been described in the 1920s and 30s, you might see evidence of a necrotic lesion and even a calcified lesion, but you might see those same type of lesion in an active TB lesion. So what determines whether one lesion goes in one direction versus the other direction? Why does some progress become active and destroy tissue, and why do some lesions regress? And why are some contained and heal completely? And if we say it's heal and contained, what exactly do we mean by that? How do we define a progressive or a regressive lesion? These are all very important points. Okay, I mentioned that before. And I've also said that all stages of human primary TB is present in most single active TB lungs. There's evidence of active as well as latent lesions in a single active TB lung. And very importantly, lesions also behave independently in the human TB lung. That's important. Coming closer to today's talk, we know that histopathology is the gold standard for diagnosing pulmonary TB, especially if you combine it with Zell-Nielsen stain. But we know that histopathology sections are 2D images, and it is assumed that TB lesion is a sphere-like structure. Carnegie or Rich have no particular opinion on that. So the question is, what is the biological significance of this shape? Does it have any biological significance? So I'm going to give you a quick overview of what we already published, and then we'll go over into those, into some data we have, which is sort of ongoing. So in terms of reconstruction in 3D of the human TB lung, we made use of micro and nano CT imaging, and this has been done by these guys, and this is a paper that we've recently published last year. And like I said, I'll talk a little bit about some of the unpublished data which is currently under review. So the question is, it might be relevant to many investigators, can we use routine clinical imaging modalities for characterizing TB lesions ex vivo? In other words, if you have a resected lung, without spending millions of dollars on micro and nano CT scanner, can you examine this lung with routine clinical platforms? For example, the conventional HRCT scan, every hospital would have them. We actually took a resected TB lung sample, formed and fixed, and we push it right in the donut and we perform our scans. We also make use, and that's illustrated in B, a soft tissue X-ray machine. This is for performing mammograms, and assess the capacity of that platform for studying the same lesion. And then we also make use of the micro CT scanner and an nano CT scanner and C and D. And to put everything in a nutshell, we took a lesion with visible lesions, TB lung tissue with visible lesions, a couple of centimeters in size, and scanned them, and we actually obtained fairly good resolution. F is the micro CT scanner, we get very high resolution scans. G and H is actually done from the HRCT scanner and from the soft tissue X-ray scanner. The soft tissue X-ray scanner was actually quite impressive. So yeah, it raises the potential one could study the 3D structure of TB pathology using conventional mammogram X-rays as well as HRCT scans. Of course, if the radiologist would allow you. But again, the tissue is non-infectious, it's formalin-fixed, so it shouldn't be an issue. So we could assess this, and like I said, this is under review, and we can compare it, we can cross-match it with the H and E stains on the right-hand side, and we can identify these lesions quite accurately. We've obtained a lot of information from these type of platforms. This is our micro CT scanner, the big one. You have to remote access it because of the X-rays. Very effective in studying. Let me give an example of how we studied a slice of human TB lung tissue from a 16-year-old girl with extensively drug-resistant TB. First diagnosed with MDR at age 4. These are different lung slices. You can see the lesions in the lung tissue. Some of them are calcified, some of them are necrotic. And when we did the scanning, this example of a gray scan, we could identify the airways. These are the yellow arrows. The blood vessels are the white spots with the blue arrows. And then the red, these are the lesions. These are the clearly visible necrotic lesions that we could identify And there's one area in particular that I will emphasize. The advantage of the micro-CT scanning is that you can quantify the number of lesions with very high accuracy. You could say, well, in this section, the total volume of the lesions is 272 cubic millimeter, and there's exactly 40 of them. So it's quantitative and extremely helpful. So when we look at these lesions in 3D, then everything changes quite a bit. So for example, the vasculature is in red here. The yellow that you see is the actually necrotic lesions, and the blue is the airway. So there's evidence of directionality. In other words, the necrotic lesions are aligned with the vascular system and more or less in the same direction. And it's our view that these necrotic lesion actually has evolved or developed within the airways, because there's a complete absence of the airways in those areas that's very dense with necrotic lesions, and vice versa in the other areas. And if you look at the bottom, the sort of the side view with the arrows, this is about a centimeter thick slices. You can see that these lesions are actually far more complex because they protrude beyond the plane of sight. So they continue. We just give you sort of a centimeter thick slice of the lesions from the side. So just making the point that these lesions are actually far more complex. Next, we went on to a different case. We look at the X-ray of one of the TB patients, the left lung. Clear evidence A and B. You see the X-ray and A, B is the HRCT scan. You can see on the top the blue circle, that's a massive cavity, and the green is the destroyed lung tissue here. And we asked, well, what's the best resolution we can get in terms of 3D segmentation from the HRCT scan? And this is about with 1 millimeter resolution. We can get reasonable images, but it's not that informative. So when the lung was removed, we received a section that's about 10 centimeters, in terms of length, approximately a centimeter, 1 to 2 centimeters thick. This is what we observed. There was evidence of an old cavity here on the bottom, and then we could see these purple area. This is also evidence of a slightly younger cavity, and then these green areas. These are all mycotomas. And pathologists, and myself included, by over time you can easily recognize them. They have sort of an orangey tint on them. So this is a cavity that's filled with the fungus, typically Aspergillus. And when we generate the 3D images through 3D segmentation of the same section, what we're actually seeing that, and this is the old cavity, this is sort of the slightly younger cavity, that these two mycotomas, or the two cavities, are actually joined. And typically you won't see that when you slice these lungs up. So via 3D segmentation, we could actually demonstrate that many of these cavities are actually interconnected. And we could confirm that it's an actual mycetoma because we could stain for the fungi, and you can clearly see the evidence of Conidia, that's classical Aspergillus species. Next, a few words on calcified lesions. Again, this is an open book cut, and the pathologist there indicate to these with pencil to these white specks here, and this is again evidence of calcification. It points to a healing process. Calcification is not unique to TB, and many disease states, calcification is simply indicative of healing. You can see evidence of these cavities here, and again, when you slice them, you say, well, okay, you can start counting the cavities. But again, like I've shown in the previous slide, via 3D segmentation, in many of these cases, these cavities are actually interconnected. So if you take a pencil and you push along the cavities, you will see it goes in the one end, goes out the other end. So there's value, significant value in terms of 3D representation of TB lesions. And there's another lesion here on the bottom here with a red circle, which is a mycetoma with evidence of calcification. So that raises, one thing that we've, in our experience, in working with these calcified lesions, we figured out that there is a potential where we could study TB pathology actually in formalin fixed paraffin embedded wax blocks. And there's millions of these wax blocks available. pathology departments typically have massive archives where they would keep, usually by law, they're obliged to keep for a certain period of time these wax blocks. And they're available for study. They're really an untapped resource. And for example, this is a sample, it's a wax block on sort of fixed on a rod that we put in the CT scanner, and you can see this white calcified lesion there. And we said, well, okay, let's see whether we can study these lesions using micro-CT. And this is a fresh formed fixed block. The green area, that is a cavity filled with a fungal ball, a mycetoma. And here on the bottom, there's white evidence of these white crystals of evidence of calcification. When we took that same block and we scan it, that's what we got. The calcium signal, no surprise, line up very, very significantly. And we also observed evidence of calcification within the mycetoma, which is very interesting because calcification is typically dystrophic. Usually they're preceded by necrosis. And as part of the healing process, these necrotic areas sort of evolve into these calcified lesions. This is the corresponding H&E, and that's just simply a zoomed-in image from what we see. So we could track exactly the features, the micro-CT feature, and cross-check that with the actual histopathology. And again, we could demonstrate that this cavity is filled with Aspergillus lesions. So if we further interrogate that same wax block in the top rows, you can see that these white blobs, this is evidence of calcification, and again they absorb the electrons very effectively, and we get very strong potent signals. And this yellow area here, that's where the mycetoma is, the cavity filled with the fungal ball. And when we perform the 3D segmentation, ultimately it boils down to this sort of cylindrical oval egg type shape here, which is a cavity, and these blue spots that we see here, that's actually evidence of calcification. And we could identify different levels of calcification in terms of the density. Some of these calcium crystals are extremely densely filled, compacted, composed of calcium, where others are slightly less calcified. And we can identify these calcium crystals on the bottom here. In a moment I'll show you a video. But just to come back to this area here, when we, and I'll show this in the video in the next slide. Let me just, okay, there the video is slowly starting. So basically the cavity represents a sort of an eggshell shape, which is full to some extent with calcium crystals, which are composed of different densities of calcification. And these ones, for example, would be the most dense calcified lesions. And as we zoom back, you'll get the less dense calcified lesions. So that whole cavity is really full with calcification. In the next video, I'm going to zoom in on one of those calcified lesions to provide evidence of some biological organization. We don't really know, and I don't think anybody knows what's the process, the evolution of this, of calcification, what exactly is involved. We know it's calcium phosphate, but besides that, we don't really know. But the videos, there appears to be these structures here, which seems to be biologically relevant, but again, we don't know exactly. So again, you might ask, why am I showing a couple of, a number of slides on calcification? So why is dystopic calcification and healing important? And it boils down to studies. A lot of these studies have been done many, many decades ago, up in Arlington in 1927, as well as a whole bunch of other studies have shown in latent TB-infected individuals that they contain calcified lesions. And when they isolate those calcified lesions and they mash it up and inject an inhibit, the inhibit would actually die. So that's evidence that these calcified lesions, to various degrees, contain MTB bacilli. So that might be a potential hideout. Now, as calcification increases, the viability of TB is reduced. Regardless of that fact, it appears to be, based on this old study, that these calcified lesions, they're an environment where TB are residing, and it contains viable TB bacilli. Because when they inject in guinea pigs die, they can isolate TB from the guinea pigs. And again, also in our studies, when we look at those TB-infected lesions, in the top right-hand corner, you can see we identify a necrotic lesion there, and then we identify a very bright spot which appears to be resembling calcification. And again, on the left-hand side here, you can see the evidence of the spectrum of lesions, and the blue here is the calcified lesion. But I want to focus your attention on this one on the right-hand side, where the red arrow is. So that is a necrotic granuloma or lesion in 3D. These protrusions look like a coral or a ginger root. And right smack bang in the middle of that necrotic lesion, there's a calcified calcium crystal, which may point to the start or the onset of healing. But again, it just illustrates the power of 3D imaging, how that could contribute to us understanding granuloma, the evolution of granuloma formation and healing. And incidentally, in this same necrotic lesion, we were unable to identify actually bacilli via zoonoses. Another, I think, very important finding, I think, that came out from our studies on micro-CT is the identification of hidden histopathological abnormalities. Now, what do I mean by that? For example, if many of you study TB, I see Covender, you there, and a lot of other TB investigators, when they look at the pathology, especially human pathology, you would see these necrotic lesions, and within the necrotic lesions, you would have this swirl of abnormalities or anomalies, which nobody can really tell you what it is. It's a feature of the disease pathology within that necrotic areas. And typically, pathologists would ignore it, just go on and look and try and find acid-fast bacilli. But with our 3D segmentation studies, when we look closely at it, we could observe evidence, in terms of the grayscale of different densities, electron absorbance. And you can scan in 3D, you can scan up and down through the sample, and we can see that those electron-dense areas, they demonstrate different densities as you scroll through the sample. And the good thing about using sophisticated software is you can ask the software to actually reconstruct in 3D those lesions, those anomalies or abnormalities within the necrotic lesions. And lo and behold, what they actually identified that came out from that necrotic lesions is actually obliterated airways. So these obliterated areas are the source of these abnormalities, which typically is not possible through conventional histopathology, simply because it's too deep. And I will illustrate this in the video. There you can see the yellow, that's the necrotic lesions, and embedded within that necrotic lesions, and these are the swirls or anomalies that I'm referring to, you can see these two, the one is blue and the one almost like a gold color, which resembles airways. So that raises a number of interesting questions in terms of the evolution of granuloma formation, and it actually is consistent with the studies in 1876 and in 1910 and 1920, where you would have massive inflammatory response, which sort of get expunged into the airways. It breaches the wall of the airways and actually fill up the surrounding areas. Necrotic granulomas have complex 3D structures, and again, this is something that we've already published. I'm going to quickly go through it. Just one slide on it. When you look at these 2D images with a micro-CT scan, you can see these grayish necrotic areas, which immediately raises the issue that medicine granulomas are not suitable because there's the potential that they might be tubular. And when you reconstruct it in 3D, and again, this is what we've already published, you can see these tubular or ginger root type structures. There's two different examples, and on the right-hand corner in the table here, it just makes the point that the smaller the lesion is, the more oval it is, and as it grows bigger, you get these cylindrical type shapes. So we moved on beyond this, and I'm going to just go quickly through this. Again, on the left-hand side, that's sort of a surface 3D radiation of a lesion. On the right-hand side, the yellow is the lesions. You can measure the distances of blood vessels or airways from the lesions, etc., etc. TB granulomas are structurally diverse, multiple shapes, all sort of shapes. And then there's evidence of bronchial obstruction. And it's evident from this structure here, where you have necrotic lesions, and these necrotic lesions, they sort of rupture into an airway. It's evident by these arrows. You can see the bronchial epithelial layer there just being filled up by these cells. And it basically follows the path of least resistance. As is evident by this model, it's just a video of the same thing here, which basically makes the point that many of these lesions are actually being generated via bronchial obstruction. Right, so again, following the road of least resistance, you have an inflammatory response that rupture into an airway, and the airway just gets filled up, and the airways actually help shaping the granuloma. This is just to give you independent evidence of an H&E within the airways. You can see this large number of cells as well as blood vessels. Another example is a massively consolidated area where you stand for epithelial cell, and you see these images, which basically just means that the airway is basically filled up with immune cells. So I always like to show this slide on your repeating history, because a lot of these studies people have shown in 1854, 1876, and Cornelia Reach, Bagel, and Medler, have demonstrated many of these observations, which we are making today with modern day technology. So there's basically an urgent need to go back to the roots of TB, trying to understand human pulmonary TB. Just to give you a summary, TB lesions are far more complex than previously thought. We can quantify a range of biological features. They are predominantly polymorphic structures. They're not balls or spherical, but some of them are. They represent tubular features, which are connected to a much bigger dynamic structure. And using 3D imaging technologies, we can now identify new structures, which is not possibly through conventional histopathology. The spectrum of TB lesions is undefined. I think there needs urgent attention. We need more post-mortem studies to help describe latent and subclinical TB. There's the potential where we can discover imaging biomarkers and also to generate a 3D atlas of the human tuberculous lung. So I'm very close to the end of my talk. I have a few minutes. In the last few slides, I just want to show something on COVID-19 pathology which has relevance to TB, because we actually, by studying COVID-19, we optimized some of these platforms for studying TB pathology. So I'm giving you one example. It's a right lung, 3 lobes, 1.5 kilograms, about 3 times the normal weight of a lung, COVID-19 lung from a post-mortem tissue. This is just how it looks in the anatomical pathology laboratory. And we slice these lungs in different sections inside 6 different slices. And this is how it looked when we use different contrast agents in an attempt to study each one of these lesions, slices in great detail. And this is one of the first slices which became apparent. This is the maximum intensity scan. This is the vasculature you see, and what we immediately observe is the peripheral vasculature here. But where's the remaining vasculature? We couldn't identify the remaining. There's a much rich vasculature in the more central areas, and it's predominantly peripherally. We say, well, actually, is this only true for this one slice, or is it true for all the slices? It turned out to be true for the other slices as well. For each one of these slices, it turned out to be exactly the same. Evidence of tortoise blood vessels there, but where are the rest of the more centrally located vasculature? We couldn't identify. This was actually previously reported more recently, actually, the so-called vascular tree in blood using HRCT scans. It's fairly low res. We obviously could go far more high resolution. So you can see this is substantial difference in terms of the resolution. But we then asked the question, well, can we scan a whole lung? This has never been done before. So although we observed this increased prevalence of peripheral vasculature compared to the central region, which is much more a bridge, we weren't sure whether we can scan a whole lobe. And this is the right lower lobe from a COVID-19 patient. And actually, it turned out that we could actually do it. So this is a video. You can see this blood vessels. There's evidence of a tortuous blood vessel, which is a sort of a squiggly blood vessel. And again, it's much a bridge to the central areas. And whatever radiologists I spoke to or forensic pathologists, we're basically at a loss why that's the case. We don't know. The important thing that we learned from that is that it is possible to scan actually with fairly high resolution a human lung. And as an example, we used COVID-19, obviously we're doing this now with TB lungs as well. The other important thing, and this is my second last slide, is what you would observe in 2-week scans would be these white blotches on the images, and it's not really meaningful. And the pathologist will be telling you, well, that's evidence of hemorrhage because you would have H&Es and you can zoom in on it. However, when you generate this 3D image, you get structures like this. So you can pinpoint the exact position of hemorrhage of the blood vessels, the exact location, which could be extremely informative. And then obviously we can identify thromboemboli, which is what we identify very easily also. So that's just an added advantage of using a COVID-19 lung to scan. Just to summarize this, COVID-19 pathology is complex. I'm not going to go too deep into that. There's evidence of vascular pruning close to the pleural surface, and micro-analysis CT is really effective in examining whole lung lobes. And there's the potential of 3D atlas of COVID-19 lung. And with that, I just want to thank all the supporters, a large number of postdocs from India, from Delhi, from Intex, Vikram and Krishna and Ritesh Salkar from Intex, Sajid also, the Niels from Delhi, etc., etc. And obviously the funders that also pay the bills. Thank you very much. Hi, who's that? Is that Governor?
Yeah, I agree. How are you doing?
I'm fine. Yourself?
Yeah, I'm doing also fine. Yeah, I have a small question. The question is, I saw you looked at the COVID-19 lung sections.
Yes.
Is there any relation or correlation you found with the tubercular granuloma with the COVID-19 patients?
Okay, two things. That's an interesting question, a provocative question. COVID-19 actually do generate cavities as well, but they don't do that frequently, right? So that's that's sort of interesting. What we did with that lung is we actually did a separate scan and only scanned for calcification. And we did observe calcified lesions. Now this is a patient who died of causes unrelated to TB. That's a COVID-19. He died of COVID-19. Right, so keeping in mind South Africa, and I don't know what the situation is in India, but it might be as high as in South Africa. On average, 80% of people in South Africa is latently infected. In the age group between 30 and 39 of males in the lower income housing areas, it's close to 85%. So let's say it's 80% people is latently infected. It did cross our mind whether this patient who died from COVID-19 also had latent TB. Obviously, you would need much more, as is evident by calcified lesions. So that's about the only connection I can make with TB. And as a matter of fact, we're looking at those lesions now because it was quite remarkable. The thing is just, with conventional HRCT and X-ray, you would miss those calcified lesions because they're far smaller. They're below the detection of the X-rays and HRCT. So with the micro and nano, we can actually go minuscule, very small calcified lesions. So I hope that, I guess it probably didn't answer question, but in our view, there might have been evidence of prior TB infection, latent infection in that COVID-19 patient. That's about it. Any more questions?
Thank you so much, sir, for such an impactful talk. We are really lucky to get our knowledge augmented by your lecture. Now the session is open for questions. Any more questions?
Thank you so much, sir, for this insightful lecture. So, as you have said that every stage of the granuloma should be quantified to study TB, and we got to know that latent TB patients have calcified granulomas. So, how can we quantify biological features or immunological features of the condition? Wherein, like, I'm a little confused on the fact that the lungs that you have harvested, isolated, are pathologically severely damaged. So, if I want to study the immunological aspect of the calcification in case of latent TB patients, and how can I target like a therapy so that can be targeted since every fourth individual is infected latently?
Ooh, it was very bad. I heard just something about calcification and how to study calcification. Maybe somebody with a better connection can just translate that question for me.
Okay, sir, actually I just wanted to know, like as you have said that we should quantify all the stages of granuloma so that we can understand it better. So how can we quantify immunological or biological features of calcified granuloma which are present in case of latent TB patients, since every fourth individual is latently infected and that can be a good target for therapy? Since it's a calcified granuloma, what kind of therapeutics we will need so as to target bacteria inside that, present inside that granuloma?
Well, I think obviously you have a spectrum of lesions as I've illustrated, right, of which a calcified lesion is one component. It's one part, one component of the spectrum of lesions. And you get different degrees of calcification. So a complete yield response is an absolute solid calcified crystal. It resembles bone. They call it bonation, bone formation. It's like a tooth, and embedded in the tissue. And then you get different grades of it. You get partially calcified. And in one of our samples that we just looked, in the old literature called it caseocalcified lesions. A mixture. There's evidence of caseation, but also of calcification. So I don't think the focus should necessarily only be on the calcification. The reason why I emphasize calcification is because it provides us with an easy landmark. So there's a technology, we can use technology that would allow us to scout for calcified lesions, and then when we identify calcified lesions, it actually turned out that the lesion, and we've just recently identified, a caseous as well as a more fibrotic lesion, which is calcified. But it's not completely calcified. So you get these intermediate states, but I think there are certain challenges when it comes to characterizing the immune response on the cellular and on the genetic level. And that challenge typically is access to human tissue. I would urge the TB community, if they want to make a valuable contribution to the TB field, is to access human tissue, access human tissue, hook up with the surgical departments, the cardiothoracic surgeons, hook up with the pathologists, because they have knowledge which is just absolutely incredible. And I'm pretty sure in India there's ample opportunity to access those type of tissue, but it's difficult. I know it has its own inherent challenges. But I think, coming back to which is one of the questions, is how do you study latent TB? Well, actually, you're in the perfect country. I think the frequency of latent TB cases in India is pretty high. That represents you with a great opportunity of looking at latent TB, obviously in post-mortem tissue. keeping in mind that 2 billion people globally is latently infected. Right, and we know virtually nothing. It's because it's mostly on latent TB. It's mostly a clinical observation. It's a clinical assessment. You ask the patient whether how does he or she feel. I feel fine or I don't feel fine, and your skin test positive. That's about what we have, and that's very little. And that contrasts with the thousands of studies that was made in the 1920s, 30s, and 40s and 50s, where they look at post-mortem studies. The only way to study TB, latent TB, or latency, is through post-mortem studies. Because then you'll end up with tangible evidence. Then you define the lesion in a latently infected individual. And that's what we need. Because what we have now is a sparse skin test and, I feel fine. In a nutshell. So I do think it represents new challenges, but if, I think we have to urgently refocus our attention to the studies that was done 70, 80 years ago, 1920s. Medler published an article of 1,265 post-mortem samples that he analyzed. And there's a lot of those investigators, all post-mortem tissue. These healthy individuals, no prior history of TB, the diet of course is unrelated to TB. But they are latently infected, and they could isolate viable bacilli from those lesions. Which means that the key to understanding latency is to study post-mortem tissue. Okay, so that was a very long-winded answer, and I hope I've addressed that question to some extent.
Thank you so much, sir.
You're welcome.
Hi, Professor Steen. I was wondering, in high TB endemic region, people are exposed with non-tuberculosis mycobacteria. So, can they affect the structure and organization of the granuloma?
Yeah, very interesting question. Actually, since we published the article on the 3D structure of the TB granuloma, I was contacted actually by a number of investigators studying NTMs, abscessus, avium, etc., ulcerans. By a number, it was quite a surprise. And in one of them, there's a study that came published by Ed Chan from National Jewish Hospital in Colorado. He actually published a very nice study, and he compared the lesion structures, if I remember correctly, it was avium and abscessus, and he could identify clear differences in the prevalence of certain granuloma features, and I can't remember what it was, but it's published. If you search Edward Chan on PubMed, you'll find the article, and he could identify very clearly in a comprehensive study differences. So that could be informative studies, but when I look at some of the images that they've shown me, the resected lung tissue, it's indistinguishable from TB. To the naked eye, it's massive necrosis, etc. So I couldn't see any difference, but I'm not a pathologist. But he would definitely able to identify differences. So again, NTMs I think is another very unexplored and very interesting area of research. And obviously with the drug problems with with NTMs, the anti-TB drugs not as effective against NTMs. I think that's a very nice, exciting opportunity for research. So very good question.
And once again, actually, male has more severity than female patient. So, do you think that granuloma and of course immune response is better in female than male? So, do you think that it also can affect the granuloma structure and organization? Because severity of the infection in the male is high.
Yeah, you know what? I don't know. I think Ed Chan's paper might have addressed that as well, because these demographics, and this is like, I think it's like a large number of patients that he looked at. Now, in the case of NTMs, I believe elderly women are predisposed to NTMs, if I remember correctly. So yeah, I simply don't have I don't have a question. I don't have an answer for that question. It wouldn't surprise me, but yeah, I cannot speak of any experience.
Thank you so much, sir.
Yeah, so thank you, Professor Steen. It was really a very enlightening lecture, and I'm sure everyone have enjoyed it. And I think we have seen the first time human granuloma so closely that, and you know, being an immunologist, I can understand the value of this sample. Your work is really fascinating, and I'm sure it will reveal novel facets of human TB. Thank you so much once again for agreeing to be as one of our plenary speaker. It was privilege hearing you. Thank you so much, Professor Steen.
Thank you very much. Best wishes to everybody in India. I love India. Thank you.
The chicken curry.
Oh, the naan. My goodness.
I think next time we can have physical meeting and we can have these things here.
Oh, I have just fond memories of ICGEB. I mean, all the TV past conferences, and I'm always waiting, when are they going to have the TV conferences again? Because I had the most amazing time at ICGEB.
Yeah.
Best wishes to everybody.
Yeah, thank you. Thank you so much.
Thank you. Bye-bye.
Moving on, it's time for our last lecture of the day, and for that, I would like to invite Dr. Mrinal Das. Dr. Das currently is a scientist at the Department of Infection, Immunity and Inflammation, University of Leicester, UK. Today, he will be talking about unveiling Immuno Metabolism in tuberculosis. Over to you, sir.
Okay, can anybody hear me?
Yes.
Yeah. Okay.
Yes, sir.
So I'll share my screen first. Yeah. So this is yeah. So I'll be talking about my Newton fellowship work, and when I talk about immunometabolism, so some of you may be disappointed because what I'm talking about is not like what you find in the literature, and people don't talk much about it. So when we talk about immunometabolism, we talk about cellular immunometabolism, like when the bacteria goes inside and how the macrophage or T cells that those are interacting with the macrophages, how their metabolic profile changes, how they are becoming more glycolytic or more exposed kind of pathways are exchanged because of the infection. Then there comes like tissue immunometabolism, where most of the work has been done primarily on obesity, where the adipose interaction between the adipose tissue and the surrounding immune cells have been talked about. Then lately, people started talking about inter-organ communications. So where people talk about how the lung interact with liver, how the adipose tissue interact with heart, and all those kind of things. So I contacted Andrea in like 2016 when I was still in ICGEB, and I told her that I want to look at the interaction between the lung and the liver. There was a primary objective was that because most of the classical tuberculosis symptoms that you see, like weight loss, like high IL-6 or high competent vectors or like aqueous proteins, those are synthesized by liver. So I wanted to see what is the response in the liver when a person is infected in the lung. So what we did was we used this conventional enzyme model of, so another thing, just to justify that why we should study liver, then I went through the literature and I could find that when the TB patients' lipid profiles and the liver profiles were investigated, and I could find that out of 19 articles, that most of the liver enzymes in the blood, they are elevated in the TB patients. And these are not drug treated, these are drug naive. We know that many of the TB drugs, they enhance these liver enzymes. And most of the lipids, primarily the cholesterol, HDL, LDL cholesterol, even the total cholesterol also, their levels are low in TB patients. Even the albumin is low because the albumin, and we know that albumin is expressed by liver. So we thought that we will use this conventional animal model and we infect them with aerosol just to see how much is the bacterial load we can see in the liver. And you can see that we get around 3 orders less bacteria in the liver, where we see that there were 6 bacteria in the lung, but only 1,000 bacteria, around 1,000 are there in the liver. And we looked at 21 days and 42 days, because 21 days it generally takes to disseminate from the lung to the other organs, and 42 days is a chronic stage, but not a very late chronic stage. We wanted to see at the early event of what is happening. And if you see, look at the infiltrating immune cells within CD45, you see that the lung is massively infiltrated with the immune cells, but you can see very minor patches in the liver. So liver is not a typical inflamed state in aerosol infection. However, when we look at the transcriptome, we do see that even there are very less bacteria, very less infiltration. The infected liver transcriptome is different from the uninfected one, and it changes as the infection goes from 21 days to 41 days. Then we did a cluster analysis, and you can see that this is uninfected, then 21 days, then 42 days. As the infection progresses, this cytokine production or regulation of cytokine production, phagocytosis, all these immunological pathways, they get enhanced. Same way like response to interferon gamma, response to interferon beta, GDP binding, all this, they get enhanced. But the metabolic pathways, that because of monocarboxylic acid metabolic pathways, or peroxisome, or piperidoma, all these goes down as the infection progresses. So basically what we see here is that the infection happens in the lung, and we also see some immune response in the liver, and but we do see that the metabolic function of the liver, there is an impact on the metabolic function of the liver. The same thing we also observed when we looked at the proteome profile. The same thing happens as the infection progresses. We see this like response to interferon beta, or here protein complexes, or but the organic acid metabolic process or carbohydrate metabolic process, all these are going down. So what do we wanted to see, that how these are different, how the lung liver infection or liver immune profile is different from the other organs like lung or in the blood. So we use the transcriptome studies that has been done by Anora, and you could see that the upregulated gene set, there is a high correlation between like the immune response. But every organs, they have a specific metabolic function, and they have very unique disruption to their function. We can see here that a triglyceride metabolic process or neutral lipid process or cellular response to carbohydrate, they are very unique to liver. Similarly, like cell junction organization or the muscle structure development is very unique to lung. So we can see that the immune profiles are similar, but they have different impact on different organs. And when you look at individually their immune signaling in the liver, we can see that both type 1 and type 2 interferons, they are enhanced in liver, but TNF alpha, IL-6 and IL-1, they are enhanced in lung, but not much in the liver. And this was surprising, because in the conventional liver immunology, we see that IL-6 and the TNF alpha, they are critical for the best protein and component factors. Those are produced in liver, but we don't see IL-6 related pathway in the liver of aerosol infection. We also try to see their interaction between these three organs, and we use an approach called ligand receptor interaction, and we see that most of the ligand that are produced by the lung, they have receptors in the lung itself, and they also have some receptor in the liver, which is green. Similarly, the ligand produced by the blood also has receptor in the liver, but there is only one ligand that has any relation with any other receptor with other organ, and that is the lung. But interestingly, this is C1QC, which is a known biomarker for tuberculosis that we find in the serum of people, for serum of plasma. Yeah, because we found that there is a response in the carbohydrate pathway in the liver, and we know that the liver is produces 90% of the endogenous glucose of the body. So we are going to see how TB infection influences the hepatic glucose production. So if you look at here, you can see that these are the glycolytic genes, and these are the gluconeogenic genes, the glucose production genes. The glycolytic genes are enhanced due to infection, which is like 21 day and 42 day. You will see here. But the gluconeogenic gene here, you can see that due to infection, it goes down. Like there is a huge impact on the gluconeogenic gene. And these genes that we are talking about, they can easily classify these three classes together. So this glycolytic gene may be responsible, maybe because of the Warburg effect that we know, but this gluconeogenic gene comes as a surprise, because we know that in TB, the TB stress glycemia that we talk about. In TB, we see elevated level of glucose in the TB person. Then why there is a suppression of gluconeogenesis? So we looked at the transcription factors that influences the gluconeogenesis, and we could find that the phosphorylation crab is highly compromised in TB patients, in TB infected animals. You can see here, like it's around 4 to 5 fold less phosphorylation of crab in the liver of aerosol infected TB. We don't see much in the AKT, which is a kind of the insulin signaling. When we see in the basal state, we don't see any difference in the insulin signaling. We see slight difference in the AMPK, which basically interacts between this crab and AKT, glucagon and AKT signaling. And related, like GSK, slight difference you can see, but the main what we observe is that phosphorylation of crab is highly compromised in infection. So this is one, how the crab phosphorylation happens. So this, it could be glucagon or it could be any other stress hormone that enhance the AMP, which basically activate the PK, and then PK goes inside the nucleus and it phosphorylates the crab. We looked at the CMP level, then we found that there is no difference between infected and uninfected anemia. So it's likely that something is happening in between this, and we are working on to find out what is happening in this person, not because the pancreas is producing less glucagon, or probably the glucagon receptor is not very effective in tuberculosis. So yeah, so when we found that okay, their gluconeogenic gene is suppressed, and in TB patients we see that some of the TB patients have very high level of glucose. In this animal, we don't see any difference in the glucose level. Then we thought that why it is happening? Then what is compensating it? What is compensating the suppression of gluconeogenesis? Or is it that gluconeogenesis is being kind of it is maintaining the homeostasis? That's something happening at the end. So what we did was a glucose tolerance test. So we give glucose and we have to see how much the infected animals are able to utilize the glucose when we give them a bolus. We don't see any difference, but we see that if we give insulin, the infected animals are not able to take up glucose. Their response to that insulin is low. So we see trend of a systemic insulin resistance in TB infection, and we see that in 42 days. Similarly, we wanted to see that whether the insulin response is, how the insulin response in the liver, and we could see that the phosphorylation of AKT, when at cell level there was no difference, but when we give exogenous insulin, that we see that the infected animal, the AKT phosphorylation is less in TB. So that means the systemic insulin resistance that we have observed, it could be related to the insulin signaling, the diminished insulin signaling in the liver. So there is a question like whether the TB induces insulin resistance or TB induces diabetes or diabetes induces TB. So we very well know now that yes, the diabetes is the risk factor for TB. So we wanted to reanalyze the study, the metabolic study from Kaufman's team. They published it in 2018. So what we did was that we took out the branching amino acid level. So what they did was that they had around 2,000 people, like those those who came in contact with a TB patient. Then they followed them for 2 years. And some of them developed TB within 6 months, some of them developed after 9 months. So they classified them as progressor, which is around 2% only, and some who remained healthy, who didn't develop TB in 2 years. So we did a study. So this is the basis of why we choose branching amino acid, because the branching amino acid is related to the HOMA, which is the homeostatic response to insulin. So this, we wanted to see whether this BCCA-related metabolic pattern has any correlation with the progressor versus non-progressor. And this is what we see. The BCCA-related metabolic pattern, it can distinguish the progressor from non-progressor, both in serum and plasma. So that means we did a double reduction from the BCCA-related metabolite from the metabolic study. We chose only those metabolites, and we see that when we did a double reaction with a score using the OPLSDA, it then distinguishes progressor from the non-progressor. Further, when we did that, okay, whether it changes as the TB, as a person is progressing to the disease, and you can see that as within 1 year of their progression, they highly correlate with the OPLSDA score, but we don't see any correlation with the non-progressor. That means that there is something related, that insulin resistance is like increasing in the TB patients as they are progressing to TB. And these are the individual patterns. These blue lines are individuals. Those shows this positive correlation, and the reds are those doesn't show any correlation. And all these are progressive basically. So here comes the this whether because these people already had some inherent issue with the metabolic pattern, that's why they are developing TB. I'm referring to one of the studies which was published recently. Okay, this should be 2021. So this was done in China, and what they did was they followed up around 500 TB patients during treatment, and they classified their glycemic pattern. So some were they remain moderate glycemic, that means their glucose profile doesn't change. Some remain consistently high, so probably they are already diabetic or pre-diabetic. So this group is interesting. This is called transient glycemia. So as the treatment progresses, they were high at the beginning of the treatment. Their glucose level was high, but as the treatment goes down, the hyperglycemia is gone. That means the bacteria is gone. Probably the systemic inflammation is gone, and their glucose level has come down to normal. So it shows that the tuberculosis can also induce insulin resistance on transient glycemia, and diabetes can also induce tuberculosis. So why insulin resistance is important, and why if we should discuss this in terms of tuberculosis is that insulin resistance appears in diabetic patients almost 10 to 14 years before he or she actually develop diabetes. So this is the insulin resistance. It appears almost 10 to 15 years before actually the diabetes is developed. So if you're saying that TB is inducing this, or in case if the latent TB is inducing this, and those are remaining untreated, then we are looking at around 2 billion people who are in the verge of developing diabetes, or part of those, even the 10% of those will be a huge number. And interestingly, in the low and medium economic countries where latent TB is prevalent, the diabetes cases are going up in the last 1 decade. So this is a very important question, and we need to look at it. So finally, this is the working model that we are working, and we are talking about that. At basal level, or before infection or uninfected animal, there will be some sort of suppression of hepatic glucose production and some level of insulin resistance, but the homeostatic glucose will be maintained. In early infection, that will go in both ways, it will go away, but still the homeostatic glucose level the fasting glucose that we have seen will remain. But in the late infection, recently Jyoti from US, she showed that after 70 days, the glucose, we see elevated levels of glucose in the mice. So after late infection, this compensation is not working, and they are more going towards developing insulin resistant diabetes, and their glucose level is remaining high. So this is the working model, and why I am talking about early infection, not about late infection, but this comes with the pH3 energy. So if you say that this was a basal level, and this is a late stage where we see elevated glucose level, but our interest is to see this one, because if we understand this, the early stage, then only we will be able to identify, like crab we have identified. We will be able to identify the mechanistic basis of how it goes heavy. So this is all, and this is the summary. So suppression of gluconeosis happens at the early stage, and it is done through crab. The MTB infection suppresses systemic immune response, and also we see compromised insulin signaling in liver, and insulin responsiveness, the disease metabolic signature, that it correlates with TB progression in TB context. So yes, TB induces glucose dysregulation. That's what I could say. And this is what I thank my lab. I also want to thank my former supervisor, Dr. Nadananda, because all these ideas came from the human studies that I did with him. So, Dr. Granuloma and his colleague, they are clinicians. So, whatever I do in they try to connect it to the human. So we need to do a lot about this, because every experiment I do, then I go back to the literature, I don't find much. But if you are interested and want to collaborate, want to produce more result in this line, then I'll be happy with it. Thank you very much.
Thank you, sir, for such a captivating talk. It was a delight to learn from you. The session is now open for questions.
So can I come first? Sorry, I keep on asking first.
Yeah, Mrinal, can you stop screen sharing?
Oh yes, sure.
Yeah. Mrinal, yeah, this is Govardhan.
Yes, please. Nice to see you.
Yeah, good to see you too. You're doing very good science, but only problem I have, your control. So you are only controlling with the TB. If I am on years too, is that take two more controls. One is basically allergy control, and another one is your other unrelated infections such as Klebsiella pneumonia or something. So that
We are doing that. Actually, we are doing a study where we are trying to correlate what is the immune response in viral infection, parasite, mycobacteria. In fact, some of the gut microbes, I have just talked with someone in the Imperial and they are doing Insulin.
yeah.
So we are collecting them, we have to see what are the common metabolic or immune pathways and what are the difference in that. And we are taking hyper-diet-induced diabetes is also one of the studies in that.
Yeah, so then only you can talk about the unique things that is induced or regulated by TB organism, but not as a bystander. Okay, thank you.
Yes.
Yeah, Mrinal, basically in mouse, when we infect TB, like when we infect mouse with TB, we can know what the stages of early infection, late infection and all. But what about in human TB, when we don't know the early infection and late infection, can we identify at the metabolic level during early infection in human?
Yeah, that is we can do only in the context study that Stephen Kaufman has done in Africa. But the issue in Africa is that there is a very if I'm saying that a person has come in contact with a TB person in say January 2022, and I'm following him for 2 years. It's very likely that within that 2 years he will come in contact with many other TB patients. So that way, in the Western, we have a very good cohort who has come from countries like India or Africa or Philippines. So they were already exposed. We can tell from their listing, from their IGRA and their skin test. But now their repeated infection or repeated exposure is less in this country. So we're using that cohort with these clinicians that I told you I'm working on that, just to understand the progression. But yeah, of course, and that late stage is important because when we see a person has developed symptoms, has gone down to diagnose whether he has TB or not. So in general, it is considered as a late stage. Because how the late stages arrive, that we need to understand what is happening in the early stage. And that we are doing through the Immuno model.
Any more questions? Okay, then thank you so much,
Okay,
sir.
thank you very much and good luck to all of you.
Thank you, sir. With this, we come to an end of the lecture series for the day. Thank you so much for your time. All the talks have given us some new understandings of TB immunology. I am sure the upcoming days are going to be equally fascinating and we are going to learn something new every day. I would now request the participants to please assemble at the Immunobiology lab for the hands-on session of the workshop. Thank you. Before the assembling in the Immunobiology lab, please proceed for tea in the faculty lounge. For tomorrow's session, we'll be beginning at 9 o'clock tomorrow in the morning. For now, please proceed to the faculty lounge for refreshments. Thank you.